Are you ready?
Yes, sir.
Okay, we'll just start in a minute. Good evening, everybody. Welcome to this evening episode of Pursue. And this is Pursue 14L, which is Hematology General and Fundamental. We are streaming live from Suraksha Diagnostics, Kolkata. And this is a continuation, the third in the series of Flow Cytometric lecture. And this is the second in the application in Hematology of Flow Cytometry, session 2. And to talk on that, we have Dr. Gautam Gopal Bhagwat. He's an MBBS and MD from R.D.Gardi Medical College, Ujjain. A PDF in laboratory hematology from the famous Tata Medical Center, Kolkata. Presently is a consultant hematopathologist, Suraksha Diagnostics, Kolkata, section director of hematology, immunohematology and flow cytometry at the Suraksha Diagnostics. He has received his fellowship in laboratory hematology from Tata Medical Center. During his training, he acquired organized and structured hematopathological reporting skills and foundational knowledge to improve patient care. He also had a 1-month hands-on training at the University of Salamanca, Spain, where he gained experience in flow cytometric analysis of various hematological malignancies and MRD analysis. In 2019, he received the Berendt Homans Travel Award, the annual conference of the ISLH in Vancouver, Canada. His areas of interest is hemato-oncology and flow cytometry. Before I ask Dr. Bhagwat to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Bhagwat sir, please share your screen and let's start.
So good evening, everyone, and thank you, sir, for that generous introduction. And I am really thankful to you for giving me this opportunity to talk on one of my favorite subjects in hematology, that is flow cytometry. This is my third talk, as sir mentioned, of this series. In the first talk, I had talked about the principles and techniques of the flow cytometry machine. We had dealt with the workflow of a flow cytometry lab. Then what is the fluidics, optics, electronics. I had explained about fluorescence and the need of multicolor flow cytometers, and also we had discussed regarding the challenges in terms of compensation that we face during the with the multicolor flow cytometry. We had also discussed a bit about quality control in flow cytometry and automation. Day before yesterday, I had my first session of applications of flow cytometry in hematology. So in that, we had dealt with the leukemias and the lymphomas, or the tumors of hematopoietic system, and I had tried to explain how we gate through various, and how we select the population of interest, and then with various case studies, I tried to go through various markers and what markers are positive in which kinds of which types of leukemias, a bit of basic approach to various BCLPDs, and also an important aspect in the treatment of leukemia, that is follow up by detecting the measurable residual disease. I had touched upon that in the last talk. So moving forward, this is my last in this series of flow cytometry. And as I told last time, I had discussed that almost all the flow cytometry has a role in almost all these disease entities of myeloid neoplasm and lymphoid neoplasms. And we'll move forward. And in this, I would highlight the role of flow cytometry in various so-called benign disorders of hematopoietic system. Um, and we will start with the lymphocyte subset analysis, what it is and how it is used in various immunodeficiency disorders. A couple of RBC disorders in which we use flow cytometry, a bit on how the platelet disorders flow cytometry is useful, and one another aspect which is very important in a stem cell transplant or bone marrow transplant setting, that is the CD34 assays. There are many other applications of flow cytometer, which of course the hematology lab would only take care of, but per se these are not related to hematological disorders, and therefore I will not go through this in this talk. Maybe other applications can be dealt with sometime else. So coming to lymphocyte subset analysis, what we exactly, the basic analysis that we do is a T, B and NK. So these are the three kind of cells, the lymphocytes: T cells, B cells and NK cells. Basic TBNK tube would have the markers CD3, CD19, CD45, CD4, 8 and CD1656. Now to although there are many subsets of lymphocyte, but those mostly used in research or in in-depth diagnosis of the immunodeficiency disorders. But this initial tube is one of the ideal screening tubes to give you idea into what the lymphocyte subsets look like. So remembering from the last talk, lymphocytes, low side scatter and bright CD45. So we would gate over these lymphocytes, and then this the T cells are CD3 positive, again divided into two, that is CD4 and CD8. The NK cells are CD16 and 56 positive. So now there can be T NK cells also, which are CD3 positive and 1656 positive also, and the classical NK cells which are CD3 negative and 1656 positive. And B cells, as we know, CD19 is a pan B cell marker. So using this a combination of these six antibodies, we can get into the various subsets of lymphocyte. Now this, as you can see, requires at least a machine which has a 6-color capacity. However, if you have a 4-color machine, this can be done with 2 tubes, but more color a machine has, more permutation combinations are possible and better it is. So coming to the utility of lymphocyte subset analysis, in research we use this lymphocyte subsets to a great extent in learning immune system of humans as well as various animals. But if we come to the disease or the clinical aspects of lymphocyte subsets, the most common use is in the immunodeficiency disorders. Now immunodeficiency disorders are heterogeneous group of disorders with defects in one or more components of the immune system. They present with wide spectrum of clinical manifestations and laboratory findings. Primary immunodeficiencies are more than 400 disease entities with around 430 gene defects. They present mostly in early childhood, but rarely might present as adolescents or adults, and they have a predisposition to autoimmune disorders and malignancy. Now, these deficiencies can be primary or secondary. Primary, that is genetic, coming from the parents, and these would therefore usually present in early childhoods. The secondary are due to the intravenous drug abuse, unsafe sexual activity, other risk behaviors which we know are the risk factors for HIV/AIDS. But other than that, you may have secondary immunodeficiency disorders related to chronic diseases, related to malnutrition, or immunosuppressive therapy such as corticosteroids, etc. Well, the most commonly used of this lymphocyte subset, that is CD348, is in HIV, or the infection caused by human immunodeficiency virus, which attacks our immune cells. If left untreated, HIV will lead to the disease called AIDS. Now, I am sure everybody is well aware that HIV infection does not necessarily amount to a disease AIDS. When do we call it as AIDS? That when the number of CD4 cells fall below 200 cells per cubic millimeter. So as guidelines suggest that CD4 is important to call someone with AIDS. So therefore, this is, now you can understand how important flow cytometry is in the patients having HIV and living with AIDS. So stage 3 HIV, that is AIDS, CD4 counts less than 200. But this is not only about CD4 count less than 200 cells per cubic millimeter. When do you start ART or the antiretroviral therapy? And there again CD4 has its important. The guidelines suggest starting this at less than 500 cells per cubic millimeter. And what are the timelines for the CD4 counts? So it is done at diagnosis, every 3 to 6 months to judge disease progression, and also to monitor the response of ART every 3 to 6 months. Now here I like to point out that a single CD4 count is usually of no use. The trend of a CD4 count is important, and therefore serial CD4 counts must be done in these patients. I'll just go through a case to explain how exactly we do this counting. A 50-year-old male was HIV positive. The peripheral blood sample was sent to us for CD348 counts. The total count was within normal range, and also the differential from cell counter was normal. So if you see, the lymphocytes are normal in the count wise, lymphocytes are normal, but let us look what the subset tells us. Now these plots are from a clinical software which gives us the counts. So here I would like to emphasize on two important points. One is, whenever we want absolute counts from a flow cytometer, we use these fluorescent label beads in the tube. These beads are nothing but polystyrene balls like things which are fluorescent label and have a very bright intensity to one of the fluorescent markers in the tube. Why these beads are important? Because we have to do the absolute count. So in the calculation, the number of beads would help us to know what the absolute count is, because the absolute count of these beads is provided with the kit, and as the lymphocytes or any CD4 count or any CD3 count we are getting in percentages. So depending on the events of these, number of events of these specific cells, we would put it into a calculation factor, and thus we can get absolute count for the various subsets. So what exactly happens is, we get a lymphocyte here, the CD45 bright, as in this case it is 44.3%. We get this as this in this plot, so only lymphocytes are being seen in this plot. We have a CD3 versus side scatter over here. So all these cells towards the right are CD3 positive cells, that are the T cells, and all these cells which are on the left hand sides, most likely B cells and the NK cells. Now this is a 4-color tube. So in this, the B cell marker, that is CD19 or 1656, is not put, but if we have those, we can gauge these cells to look for whether these are CD19 positive or 1656 positive accordingly. Then these CD3 positive cells, we would again look only on this population in a CD4 versus CD8 graph. And if you see this is CD4 positive population, this is CD8 positive population, and these few events are CD4, CD8 both positive. However, we have almost nothing or around 1% cells in the CD4 and 8 negative. So this is a very usual pattern to get, and that is CD4 and CD8 cells and few CD4 plus 8 positive cells and hardly any CD4 and 8 double negative cells. So in a peripheral blood, the mature T cells would usually have this pattern. The CD4 to 8 ratio is usually 2:1, may range from 0.7 to almost 3, but usually it is 2:1 in the peripheral blood. Now what are we going to do with these numbers? We will put this into some calculation factor. So what I have here is that the CD4 lymphocyte count is 4445. Now this cell count divided by these bead count. So beads we have 2006. We multiply it by the given factor, the total bead count that is in the kit literature, and then we divide it with the amount of blood that we have put in. Now here I would like to tell you that there is a difference in the processing of this sample. So here we use a technique called as reverse pipetting. What is reverse pipetting? So ideally when we pipette out something, we would press it till the first stop. We'll press the pipette till the first stop, take the blood, the desired quantity of the blood, and then we will push the entire amount into the tube. But in this case, what happens is, as the blood is viscous, some of the blood tends to stay back into the tip, and we don't want that because we are going to give absolute counts to the patient. So a 50 microliter of blood should be 50 microliter of blood and nothing more and nothing else. So for this we would do a reverse pipetting. In that we push the pipette button entirely to the bottom, we take the blood filling the tip full and then press till the first stop. So whatever, so for example I have put it as a 50 microliter in my pipette. When I press till the first stop, only 50 microliter will get out, rest I can discard. So this ensures that the exact amount of blood has gone in this analysis, and this is important because we are going to give absolute counts. So then with all the calculations we get that the CD4 count is 2169, which is correlating with what the cell counter was giving. But if you see here, what I get is the percent CD4 is only 20% or 18.56% with 400 cells which are CD4. CD8 1200 cells, around 60%, and the CD4 is to 8 ratio is reversed. That means in a HIV positive patient, this means that the CD4 cell count has gone down and needs some treatment intervention. Now I didn't have any history regarding this patient in terms of whether he was on ART or not, but if we presume that he knew that he is HIV positive but he is not on ART, then this is the stage when the clinician would start ART for him. Knowing this, so this is the report that we would be generated, but we also need to know the reference values for CD4, CD4 is to 8 ratio, CD3, etc. depending on the age, because therein lies the importance of whether these counts are really low or not. So as in any other parameter that we say, that reference ranges for the age and sex are important. Similarly in CD4 counts also the reference ranges are very, very important. Going to the primary immunodeficiency disorders. So now, as I said, that there are almost more than 400 entities with 430 genetic signatures. 2019, this International Union of Immunologic Society came up with this phenotypical classification of the PIDs or the primary immunodeficiency disorders, in which they categorize this into 10 different parts or 10 different classes. First was the immunodeficiencies affecting cellular and humoral immunity. then associated with syndromes, then antibody deficiency, immune dysregulation, defects of phagocyte number or dysfunction or both, defects in intrinsic innate immunity, the autoinflammatory disorder, complement deficiencies, bone marrow failure, and phenocopies of PID. Now, going into all this is not the scope of this talk, I think, and I would just try to explain how we use flow cytometry with in this primary immunodeficiency disorders with one or two cases. But before that, let me tell you why we are using this flow cytometry, because flow cytometry, as I told, with the lymphocyte subset analysis, we get a good understanding of the immune system. We can simultaneously identify physical cell properties and functions along with numerous gene products at the rate of thousands of cells per second. So we are analyzing many cells at a point of time. Therefore, this becomes a very important tool for screening and diagnosis in PID. Now, PIDs are very rare disorders. The frequency in US is around 1 is to 2000, one in 2000 cases, but still I guess US government has made it mandatory for PID screening in almost all the newborn cases. Flow cytometry gives us the information on these specific subsets or the abnormal expression of markers and abnormal function, and therefore flow cytometry plays a very important role. So all the screening that I told of this newborn would be done through the flow cytometric analysis, and the initial screening tube usually is the TB and NK tube. So coming to the first class, that is the severe combined immunodeficiency, and this is one of the most commonest primary immunodeficiency disorders, and in that also the X-linked gamma globin X-linked globin deficiency is the most common SCID. Now, how do we approach to these cases? So mostly these cases have a T cell lymphopenia. So if we combine T cell lymphopenia with a B cell lymphopenia, we would have two options, NK cell lymphopenia also. So the diagnosis would be reticular dysgenesis or ADA deficiency. So further genetic testing will have to be done, but at least we narrow down the diagnosis by use of this TBNK, and similarly so on so forth. I won't go into much because this is something which narrows down the diagnosis, and then we direct in which direction should the molecular testing be done. So I'll just present a case with a 6-month-old child with lymphopenia, history of chronic fever and oral lesions. TBNK tube was done. What we find here was CD3 cells, that is the T cells, are markedly depressed, and obviously CD4 helper and CD8 cytotoxic cells, which are the CD3 cells, are markedly depleted. So the T cell, there are no T cells in the peripheral blood. If we see CD19 positive B cells, the number is within the normal range for that age and sex. So the B cells are present, but if we see again 5616 positive CD3 negative NK cells, again they are markedly depleted. So if we go back to this chart, so this case is T cells negative, B cells positive, and NK cells negative, and this is a gamma chain deficiency which is seen in almost 50%. This is the most common immunodeficiency, the SCID T minus NK B positive, which is the X-linked SCID, which has mutations in gamma chain gene. So further we can do the genetic testing to confirm whether this is the X-linked SCID or not. So this is how we use this TBNK tube to screen our primary immunodeficiency disorders. The next case is an interesting case of a 4-year-old child presenting with organomegaly and lymphadenopathy. So also there was lymphocytosis in the peripheral blood. So first it was thought that it is a leukemia, then the clinical query went that it might be some kind of lymphoma. We also did the entire panels for leukemia lymphoma. But then going into the diagnosis, I'm just presenting few of the plots over here. So going into the diagnosis again, if you see, the population of interest are these lymphocytes. So lymphocytes, low site scatter and bright CD45 expression. When we see a CD3 component, we see there are lots of cell in this CD3 component. So most of the cells, most of these lymphocytes were the T lymphocytes. So usually what we do is we would see for the CD48 expression, and as I told, there is a beautiful pattern to CD48 with 4:8, almost 2:1. So many events in the 4, many events in the 8, and few events in the CD4 and CD8 positive component. But what we saw in this child was that in the CD4 and 8 negative compartment there were many T cells. So ideally we should have had these cells and few cells over here, but none cells over here. But in this case what we found was that these cells were CD4-8 double negative, and when we gate on these cells with TCR alpha beta and gamma delta, so these are two receptors of T cells, TCR alpha beta, TCR gamma delta, and when we see this double negative cells, what we find is almost all these cells which are double negative express TCR alpha beta. Basis of all these, along with organomegaly, lymphadenopathy, lymphocytosis, a diagnosis of ALPS was made, ALPS acquired lymphoproliferative syndrome, and the diagnostic criteria also says that the two things which are required are: one is the chronicity of a non-malignant, non-infectious lymphadenopathy or splenomegaly or both, and second is elevated CD3 plus, TCR alpha beta plus, CD4-8 double negative cells. So we found this, although there are other accessory and secondary criteria to be fulfilled, but these are other biochemical tests which are rarely done at, not done in many centers. So we have, I think, sent this sample, but I'm not very sure. So but on basis of these two above required, we made the diagnosis of ALPS. Coming to COVID-19, so now for the last 1.5 years we have been stuck in this phase of COVID-19. So now there are two eras, at least in my life: a pre-COVID era and most likely a good post-COVID era. But still, if on a serious note, if we see COVID-19, there are so many predictive markers that have come up. In hematology, we had NLR ratio. With in biochemistry, we had IL-6 coming up, or the CRP levels. With the coagulation, we had D dimers, and there were so many predictive markers. But there were many studies done in mostly in China and European countries with this TBNK in COVID-19. There are beautiful articles with meta-analysis on what this lymphocyte subset counts are in COVID-19 patient, and lately the baseline for these subsets have been set, and there are so around 200 to 350 cells per cubic millimeter. Less than that is a red alert in terms of CD4 and CD8 cell count. So there are various baseline counts below which are present in different studies have given different cutoffs, but still the consensus is less than 350 around is a good cutoff to be kept. What exactly where is this being used is in triaging the patients, the COVID-19 or SARS-CoV-2 infected patients in for hospitalization. So CD4 counts less than the cutoff, or CD8 counts less than the cutoff, are single independent predictors for ICU admission, ventilation, or putting the patient on ventilator, as well as mortality. So they being the single most important predictors. Now many centers have come up with the analysis of TBNK, more specifically the T cell subset analysis in COVID-19 patient, and triaging the patient and suggesting who should be hospitalized, who should not, and this becomes very important with the resources that we have and with the situation that we faced during the second wave of COVID-19. So this is something which many centers in India have started studying. Few of the centers have started providing as tests. So this is upcoming, and a lot of things to be learned in this and read through the articles on the internet. So I just wanted to put this slide to inform that the role of flow cytometry is also there in a COVID-19 situation. Moving ahead with flow cytometry in the RBC and platelet disorders. So now this is the list in which in the RBC category that we can look into. So first is the paroxysmal nocturnal hemoglobin urea, the hereditary spherocytosis, immature reticulocyte fraction. So this is being used a lot in various cell counters, and the indication being transfusion in dengue affected patients. So the immature reticulocyte fraction, if is high, it indicates a good bone marrow activity, and therefore we know that the platelet counts which are low in dengue will come up nicely, and transfusion is not needed in those patients. So that is the utility of immature reticulocyte fraction. Then you can detect fetal RBC contamination with maternal RBC contamination. Also, red cell survival studies can be done using various isotopes, and also certain centers do the measurement of HbF cells in monitoring the sickle cell disorders. However, I'll not go in all the applications. I'll just stick to the first two of these, which are very commonly used. And immature reticulocyte fraction again is a part of CBC analysis rather than I putting up this in this talk. The other three I would not be taking in this talk because they are very rarely used applications. Also, flow cytometry has role in platelet disorders, and the most important is that it is the gold standard for platelet counting. So we do platelet counting by various methods using the impedance, the optical, the manual microscopy, the phase contrast, which was one of the gold standards before ICSH suggested that platelet counting gold standard should be based on the flow cytometry, that is the platelet to RBC ratio. Along with that, there are various applications in the platelet function disorder. Flow cytometry plays a crucial role. So coming to paroxysmal nocturnal hemoglobin urea, PNH is a stem cell disorder with acquired mutation of the PIGA gene or the phosphoinositide glycan A gene on the X chromosome, important in making GPI protein anchors. So any protein which sticks to the surface of cells will either be sticking to the transmembrane protein or to the GPI linked protein. Now what happens in PNH is that there is inhibition in linking of certain proteins to this GPI, and the most two important ones are the CD55 or the decay accelerating factor, and the CD59 or the membrane inhibition of reactive lysis. So these two proteins are linked to GPI, and in cases of PNH, these two CD markers or these two proteins are absent on the GPI. So what happens? When these two proteins are present, a normal red cell is protected from the complement attack. Now, in a regular day-to-day life, some complement activation happens in terms of activating complement 3A, but those cannot attack or lyse the RBCs because of presence of the CD55 and CD59. But in a PNH case in which there is no GPI, this would attack, leading to intravascular hemolysis. Thus, free hemoglobin is released in the blood. The most important symptom or sign being the anemia. But along with that, there are so many clinical features. Some have significant impact on the survival. most of these have a significant impact on the morbidity. There is a triad consisting of hemoglobin urea, thrombosis or Budd-Chiari syndrome, and aplastic anemia for paroxysmal nocturnal hemoglobin. When do we do pNH testing by flow cytometry? So first is the presentation of anemia, thrombosis, dark colored urine, intermittent abdominal pain, esophageal spasm, dysphagia, etc., along with a bone marrow dysfunction. So now bone marrow dysfunction can be in form of aplastic anemia. If it is aplastic anemia, we directly go to the flow cytometry to test whether there is a pNH clone present or not. If there are unexplained cytopenias, again we would directly jump to a flow cytometric analysis to look for the pNH clone. However, if MDS is proven cytogenetically and morphologically and with other modalities, pNH is not required in adult patients. But if we have young patients presenting with MDS or hypoplastic MDS, then again pNH testing is advised. Then in the cases of hemolysis, we would first rule out the other causes of hemolysis, and most importantly the autoimmune hemolytic anemia or the drug-induced hemolytic anemia, which are the Coombs positive hemolytic anemias. And if this comes negative and we have ruled out the other hemolytic anemia causes, that is the intravascular hemolytic anemia causes, then we would go for the pNH testing. And any unprovoked thrombosis or unusual site of thrombosis warrants pNH testing done. So age-old complement-based tests and gel card techniques now are rarely used, and flow cytometry-based assays are the gold standard for testing. Molecular diagnostics tests are still confirmatory, but again the expenses are a lot. So how do we do a diagnosis of pNH with flow cytometry? So there are rule of two lineages to be tested, 2 gating markers per lineage, and 2 pNH markers per lineage. The sample preferred is EDTA whole blood, but heparin or citrate tubes are also acceptable. So as I was telling, 2 markers for pNH. So what is FLAIR? FLAIR is fluorescent labeled aerolysine. So this specifically binds to the GPI, and if GPI is absent, the FLAIR would not bind, which can be detected on the flow cytometry. CD55 I have already told is the DAF or the DK accelerating factor, and these two are the pNH markers. 2 gating markers usually we use are CD45 and CD15 or CD33. CD15 for, and these are the lineage markers also, CD15 for neutrophils, CD33 for monocytes. So CD33 or CD14 for monocytes. CD33 is brightly expressed in the monocytes. RBC screening can also be done, but we usually do granulocyte and monocyte screening, because any two, if done, is good enough as per the guidelines. The procedure is stain, lyse and wash. So what we do is first we analyze 50,000 events, and if we find any population in the pNH positive area, then with reflex we would collect another 250,000 target events, so that we get a high sensitivity assay going down to 0.01%. Now why this is important is, to make a diagnosis of pNH, it is required that we get at least 5,000 granulocytes and 3,000 monocytes. Now as we all know that pNH usually presents with cytopenias, and with leukocytopenia, to get these 5,000 granulocytes and 3,000 monocytes we need at least 3 lakh events, and only then we get a very high sensitive assay. At least 4 events should form a cluster to call it positive, and then we have something known as lower limit of detection, that is 0.001%, or lower limit of quantification. So the difference is, one, we can detect something, but we cannot quantify it with confidence. The lower limit of quantification is the limit at which we can with confidence report the percentage of the events. Now why I say that we use WBC assay is because it is a robust assay, and till 48 hours there is hardly any variation in the clone size. However, if we are going to do a RBC analysis, then RBC are subject to lysis due to the storage conditions, and therefore the clone size may vary, and therefore the most commonly used two lineages are granulocyte and monocytes. However, nowadays we are coming up with three lineage analysis to get higher sensitivity and specificity. How do we interpret the result? A PNH population of more than 1% is a PNH clone or a major clone. A PNH population of 0.1 to 1% is a minor population or a minor PNH clone, and less than 0.1% is rare and reported as such. I will try to explain this again with a case. So this is a case of a 27 years old male, comes with complaints of weakness since 3 years. He was his hemoglobin 9.4, TLC 4100, platelet 118, reticulocyte 6.6. LDH was very high, bilirubin 4.08 with almost all unconjugated. He was receiving some immunosuppressive therapy since August 2015, and also had red blood cell transfusion in 3 years. So now we had to rule other causes of hemolytic anemia. ANA was negative, DAT was negative, and what we saw in his urine when we did the pearl stain was the hemosiderin crystal. So hemosiderin positive, that is hemoglobin urea in the urine, that is hemoglobin urea. So we did a flow cytometry. Now the first step is a CD45 gating, which I have not kept in this, but after a CD45 gate, we would get two populations. One is the neutrophil population, CD15, and another is a CD33, bright CD33 population, that is monocyte. What exactly are we going to do is, if we see a normal control, if a normal case, if we see, what you find here is that this population is positive for flare as well as CD55. Now that means flare and CD55 both are bound to the cell surface. So as I said, flare would go and bind where GPI is present. If GPI is not present, it will not go and bind, and CD55, anti-CD55 antibody is put. So if CD55 is present, we will get all the events in the double positive area and nothing in the double negative area. But if we have a patient with PNH, the flare won't go and bind to the GPI. There would be no CD55, and what we get is almost the entire population in the double negative area, that is negative for flare as well as CD55. What we report is a major PNH clone is present. Now depending on the percentage, we will report it as major or minor clone, as I have already explained. What are the outcomes for this PNH patient? So a classical PNH with a major clone has a treatment option, and if inadequate response, we can do with other treatments. A subclinical PNH, usually there are no specific therapeutic options, but then we search for any underlying disease, if any, for example MDS or aplastic anemia. And if we already know that there is a bone marrow disorder present, then we try to treat the bone marrow disorder, that is. But if a large clone is present, then again this acilizumab is helpful in treatment. Coming to the next RBC disorder, that is hereditary spherocytosis. Now hereditary spherocytosis is a congenital disorder characterized by an inherited defect in the RBC membrane cytoskeleton leading to formation of spherocytes. Now the lipid bilayer is linked or attached to the cytoskeleton with means of various proteins. So spectrin, ankyrin, and protein 4.2 being important in hereditary spherocytosis, and these form the band 3 protein complex, and defect in any one of these will lead to hereditary spherocytosis. However, on the other hand, if you look protein 4.1 and spectrin, the defect in any one of these will lead to hereditary eleptocytosis. But here we are focusing on hereditary spherocytosis. So this band 3 is important. While come in the next slides. What are the tests for hereditary spherocytosis? So classically we had the osmotic fragility test, which is a test which in my MBBS days I learned in my physiology practicals, but nowadays I think nobody is doing osmotic fragility. Similarly, acidified glycerol lysis test and cryohemolysis, these two tests have lost the importance because of two reasons. One is that they cannot differentiate between hereditary spherocytosis from secondary spherocytosis, and second is we have a very high specificity test, that is the Ema binding test, and this Ema binding test is eosin 5 melamide test. This fluorescent dye binds covalently to lysine 430 in band 3 protein of the red cell membrane. So in a normal individual, the EMA would go and bind to this band 3 protein and would give a good intensity when we look into the or we analyze in the flow cytometer. But if the band 3 protein there is some defect, then this EMA will bind to the less number of band 3 and therefore will give a reduced fluorescence intensity of these EMA labeled red cells. So in cases of hereditary spherocytosis, what we are going to get is a decreased fluorescence intensity for the EMA labeled red cells. Now when we do a test, what actually we do is we run normal individual samples, multiple samples for normal individuals, and compare it with the patient sample. Patient sample usually is run in duplicate, so we take a mean of all the MFIs, that is mean fluorescence intensity from normal, and we take the mean from the duplicate runs of the patient sample, and then we take a ratio and accordingly we interpret whether the disease is present or not. We usually put a negative control also just to check the autofluorescence. I will again explain with an example. A 5-year-old girl, hemoglobin 10, presence of spherocytes, occasional NRBCs in PBS examination, splenomegaly was present. So this is the tube, the negative control. Now here this is the forward scatter versus height versus area. So this plot, if you would remember from my last talk, was being used to gate out the singlets, that is the population of interest, and we don't want the doublets to be included in our analysis. And then with this side scatter and the forward scatter plot, we gate the RBC population. Now in my last talks, the RBC population was always coming somewhere over here, that is the debris area. But the difference between these two plots, that is the plot we use in leukemia lymphomas, is that the scale is linear, while in this the scale is logarithmic, and therefore with this logarithmic scale we get this RBC population to be coming over here, because we know that the RBC has some size and would scatter a bit. Then obviously this is a negative control, that is we have not put EMA in this tube, and therefore we get the autofluorescence or the negative intensity, and accordingly we would decide with a 1 log to 2 log difference where our positive sample should fit in. Coming on to the actual test, so what we did for this case was we took 6 healthy individual samples, put EMA into the tube, and then gated the RBCs, and then looked for the histogram in the FITC channel, that is in which we had put the EMA. So as you would remember from the last slide, that the negative was somewhere over here. This is the positive control, and if you see, this is the P3. And for P3, my mean fluorescence intensity is 6239. So similarly, we did 6 samples. We take this value for all the 6 samples and calculate the mean. Also, we do it for the patient sample. And patient sample, if you see P3, the intensity is 4108 in the FITC channel. So what we did was we did this patient sample in duplicates and then took the mean. So the mean MCF for all 6 controls was 6177. Mean MCF for this test run in duplicates for 4164. 4164 divided by 6177, we get the ratio of 0.76. Now what is the meaning of this 0.76? So the interpretation is less than 0.8, it indicates that it is either hereditary spherocytosis, CDA2, hereditary pyropoikilocytosis, elliptocytosis, or ovalocytosis. So if we see, the most common of all these is the hereditary spherocytosis, and depending on the clinical symptoms and the peripheral blood smear morphology, we can come to a diagnosis. However, if required, we can go for further testing to look for the gene defects to make a confirmatory diagnosis. If this ratio would have been between 0.8 to 1.2, it would be a normal or no membrane defect, can be seen in iron deficiency anemia or thalassemia. More than 1.2, we have macrocytosis, the stomatocytosis, the pyruvate kinase deficiency, and CDA type 1 disease. So not only hereditary spherocytosis, EMA can also be used in the screening of various other congenital hereditary hemolytic anemias, but the most common of this being the hereditary spherocytosis, most commonly used to screen the hereditary spherocytosis. Coming to the platelet count, so as I said, it is the ICSH reference method for platelet counting. What exactly do we do is we put a CD61 to the sample, and then we have these platelets which are positive for CD61, and on forward scatter we know that the RBC size is more than platelets, and I have been emphasizing forward scatter is equal to directly proportional to size. So RBCs are here. There are some platelet RBC coincidences which will be counted in both. These two are the similar plots. In this we have put a quadrant. In this we have put a bitmap like thing, and a quadrant, if you see, some RBCs are going over here, so therefore quadrants are not usually advised. A bitmap plots are advised. So this is a general recommendation. However, a quadrant can also work. So with this, what we get is platelet to RBC ratio. So once we get platelet to RBC ratio, the next step is to look for the total RBC count from any standardized cell counter. Once we have platelet to RBC ratio, once we have a total RBC count, it becomes a normal calculation to calculate the number of platelets, and this is the reference method for platelet counting. So apart from counting, platelet disorders are mostly the platelet function disorders. We know the role of platelet in hemostasis. With any injury, the primary hemostasis platelet plays the most important role. First, it would go and adhere to the endothelial membrane with the help of GP1B receptor and von Willebrand factor. Once this adhesion occurs, the platelet will aggregate, and the various platelets will aggregate together with the help of GP2B/3A receptors, and once this happens, this becomes the bed for the secondary hemostasis on which the clotting would occur. Now, as I have talked of antigens, so there, if we target monoclonal antibodies against this antigen, it would be very easy to diagnose this diseases theoretically, and that is where the role of flow cytometry comes in. Getting to an example of Glanzmann thrombocythemia. So if you see, we put GP1BA monoclonal antibody against GP1BA monoclonal antibody against 2B and 3A, which is CD4161. So what we get is that because in Glanzmann GP1BA is not deficient, you will find both these histograms overlapping over each other. But in congenital Glanzmann thrombocythemia, the GP2B3A would be on the negative side in comparison to the normal control, and thus the flow cytometry would help in diagnosis of Glanzmann thrombocythemia. There are advantages for flow cytometry in this platelet function disorders. We need a small sample volume, a very short time for analysis, and we can study the characteristics and functions even if the platelet count is very, very low, and also it can be done in the whole blood. but it has its disadvantages. It is expensive in comparison to other methods, most importantly the aggregometry. The sample must be processed immediately after collection. Um, Now this can have in recent years this has been overcome by using fixing agents, and there is lack of standardization. Now again this many centers are looking into it and coming up with standardized protocol for platelet function analysis by flow cytometry. In fact, in 2014 there was guidelines from the ISTH for the platelet disorders. So any clinical if the clinical symptoms suggest that it is a platelet function disorder or a disorder related to primary hemostasis, what we do is we do a platelet count and the routine coagulation tests. If the routine coagulation tests are normal and the platelet count is normal, most likely it is a platelet function disorder. Now what we do with these samples is, so there are 3 steps to testing. These are the guidelines from the ISTH. I have very limited experience because I have not done these kind of experiments, but this is all theoretical. So first step would be the morphological analysis, and as we all know, small platelets are Wiskott-Aldrich syndrome, the large platelets are Bernard-Soulier syndrome, etc. And along with that, we may have Dole-like inclusions in the MYH9 disorders. But and the next step which we usually read is the aggregometry assays using the ADP and the ristocytin and the collagen, and looking into the first wave and the second wave, also known as the REPA testing. So these are the tests which are more common, but flow cytometry again screening is important in cases specifically which are GP2B3A. As I told, in Glanzmann thrombocythemia there is definite role. Monoclonal antibodies against GP1B, Bernard-Soulier syndrome, again flow cytometry has a role. Not only in this first step, in the second step also we can look for the platelet procoagulant activity and designate disease depending on the activity of platelet procoagulant. Also mixing tests can be done to classify the von Willebrand disease using the flow cytometry in the platelet function disorders. The third step is more of a biochemical study and the molecular genetic diagnosis. So in short, there is a definitive role of flow cytometry because there are defects in the antigens. So any monoclonal antibody targeted against these antigens would give us at least a very good screening for these rare diseases. Coming to my last application of flow cytometry in the hematology lab, and this is one of the most important applications after diagnosing leukemia, lymphoma, and this is the enumeration of CD34 positive cells. So any institute having a bone marrow transplant unit has to have a flow cytometer in vicinity for this CD34 positive or the hematopoietic stem cells enumeration, because accurate enumeration is crucial in estimating the adequate dose, and giving an inadequate dose might lead to a bone marrow transplant failure. So therefore knowing the adequate dose beforehand, before putting the stem cells into the transplant recipients, become very, very important. We employ the ISH-AGE protocols, that is the International Society of Hematotherapy and Graft Engineering protocols. The tube contains of a CD45-34 and 7-AAD. Now what is this 7-AAD? 7-AAD is a viability dye. It is a nucleic acid dye. So if a cell is viable, the transport proteins are functioning, this 7-AAD dye would go inside and would go inside, but the transport proteins would again throw it out. But if a cell is dead, this 7-AAD dye goes inside and binds to the DNA, and therefore 7-AAD positive cells are the dead cells, while those cells in which the transport protein are actively functioning, this 7-AAD dye won't be able to go inside and stick to the DNA, and therefore 7-AAD negative cells are the viable cells. Why this is important? Because stem cells are stored at sub-zero temperatures after collecting it from the donor, and in this duration of storage there are chances of viability getting lost. So transplanting non-viable cells again doesn't hold any importance. So what we do is, not only we give a CD34 count, along with that we also tell what is the viability of the cells. So this is again clinical software similar to what I had shown in the CD3, 4 and 8. Here again we gate on the lymphocytes, we gate on the CD34 positive cells, and we gate on the viable viable CD34 cells, and we get various counts. We put it into the calculation factors and we can get the absolute CD34 positive count. Dosage of 2 to 5 into 10 to the power 6 per kg body weight is something which is required or is acceptable. So by calculating this CD34 cells, we calculate the dose of the CD34 cells, and if it is adequate, it is transplanted to the recipient. And thus this, therefore I say this is the most important equipment required in a along in the vicinity of a bone marrow transplant unit, because without knowing a CD34 count or the viability of the CD34 cells, it doesn't make any sense transplanting such cells. Well, here I would just wrap off by summarizing that flow cytometry is an integral part of any hematopathology laboratory. It is the mainstay in diagnosis and lineage characterization of acute leukemias and CLPDs. There is a role of flow cytometry in almost all the tumors of the hematopoietic system. It is an essential modality in follow-up of leukemia and must be a part of any state-of-art hematopathology lab catering to the patients of leukemia for the measurable residual disease detection. It has its diagnostic role in immunodeficiency syndromes, as I mentioned, in primary as well as secondary. So very important in diagnosis and follow-up of HIV patients. Almost all HIV patients do their CD4 counts on a regular basis, and therefore flow cytometry plays a very big role in the treatment and follow-up of these patients. Diagnosis and screening of few of the RBC and platelet disorders, as I have mentioned, and it is a requirement in any bone marrow transplant facility. To conclude, again, a good sample, a good machine, a good in terms of machine in which you have the quality controls in check, a good software giving me possibilities of making all the permutation combinations, giving me good resolution, the standard operating procedures for your lab, a wisely chosen panel with minimum resources giving maximum output, external quality in place, and of course good scientific officers or technologists having very good technical skills and hematopathologists to analyze these are essential in a flow cytometry lab. Thank you very much, and I really am grateful to Dr. Nadeem, because in the course of these three talks I revised most of the things which I had learned in my last 3 years. Not only that, I came across few papers and read after so many days. So even it was good learning experience for me. I hope all the postgraduate students and residents who are listening to the talk and who would listen to the recordings on the YouTube gain a lot from these three talks, and these would be helpful. Thank you very much.
Thank you so much. A very big thank you, Dr. Gautam, for this wonderful 3 sessions, which almost completes the A to Z of flow cytometry, or rather I would say A to Y of flow cytometry. You have really done justice to your job and your presentation. Extraordinary presentation, very well done. Like Dr. Nilesh wrote, simply digestible. That's right.
Thank
Absolutely
you.
simple, to the point, very important, and very pertinent. No tamasha, ekdam baseline, but real core material. That is exactly what good teaching is all about. And I think
Thank
that is what we wanted you to give. You can just put your video on so that we can
Sure,
see
sure.
you.
Yeah, sure.
Uh, that is exactly what everybody wanted, and I would just like to tell you the last comment, which Dr. Nilesh Kapadi is a very well-known pathologist from Ahmedabad. He's a very well-known person in the pathology arena, and he has written, "Ye dil mange more," and that I agree with it 200%. And I am not going to let you go. Maybe after a month or so, maybe after 1.5 months, we will ask you to come back and speak on some other
Sure, sir.
series of topics on hematology. The students, the consultants, the senior consultants, everybody listens to these lectures, and they really gain a lot. Learning is never age dependent. It's an
Yes.
absolutely age independent phenomenon, and everybody is learning, and one person who's learning the most is me. I'm going through all these lectures, listening to it, and definitely improving my knowledge and understanding my ignorance, and to the fast changing science of hematopathology. And I cannot thank you more than what you have done a wonderful job to this platform,
Thank you.
to the
Thank you.
nation, to the community per se. This entire thing is getting recorded. We are putting up these recorded versions. We are sharing the PDF. This is, you can say, a selfless task which you are doing to the community. So many people across the country who do not have access to flow cytometry or to access to teachers like you, they are going to learn this subject, and so that makes you immortal in the system of education.
Thank you.
Thank you so much.
Those kind
Uh,
words, sir.
no,
Yeah,
no, I
I'm a
am
student
telling you
of
the
the
truth.
system also, sir. So, and it would be my pleasure to take any other topics. So, hematopathology is something which I really like to talk on, and whatever I can do, I would gladly do that, sir.
Thank
Yeah.
you so much for that offer. You cannot imagine how much, because we keep getting these feedbacks on Telegram, on YouTube, personally on my emails, on my mobile, of how people are so grateful to these teachers who come up and speak and teach. And across the country, across the globe, Southeast Asia, Europe, America, our neighboring countries, people are listening, learning, improving, and are being ever grateful and thankful to teachers like you. Thank you so much.
Thank you.
I know you are a very, very busy pathologist. Suraksha is a very big lab, a very busy lab. To take out time from your work schedule and come and teach, it is a wonderful devotional work. God bless you. Thank you, Dr. Gautam. Please share the PDF.
Sure,
Ever
sir.
grateful. Thank you so much.
Thank
Take
you.
care. God
Thank you.
bless you. Bye.
Thank you. Yeah.